My enthusiasm for this technology really has been stemmed from the enthusiasm of my clinical colleagues who are not, they don't mince words. They're very excited about the role of breast CT. I'm a medical physicist. I'm not a medical doctor, but I work closely with the medical doctors in my clinic. As we looked at the data, it was clear that when you have contrast-enhanced breast CT, it can replace virtually all other diagnostic examinations, including mammo, tomo, ultrasound, and even MR. My physician colleagues have really been a motivating force for this project all along. Their enthusiasm has really buoyed me. My job in the long run was really to write grants and try to get the funding to keep the lab active, and I've been successful with that for 23 years now. Compared to mammography, which is a 2D imaging modality of a 3D breast, it's well known, even though mammography has been definitely shown to save lives, the sensitivity averaged over women of different breast densities and size of breasts is about 70%, meaning that you miss 30% of the cancers if the cancers are there. And that's just not good enough, right? And that has to do with the 2D nature of imaging device for a 3D breast. Especially in granular, high-density breasts, the granularity of the breast can obscure the presence of a lesion if a lesion is there, and that's one of the biggest limitations of 2D imaging mammography. A lot of people like to talk about tomosynthesis, which is really limited angle tomography, and it does not give you 3Ds. 3D implies that you could look at the images XY, YX, and ZX, and you can't look at that in tomosynthesis. The thickness dimension in tomosynthesis, the voxel sizes are on the order of 8 millimeters, which is not an image. We did do a comparative study between contrast-enhanced breast CT and contrast-enhanced tomosynthesis, and we couldn't even see the contrast on tomosynthesis. We use sensitivity and specificity as the metrics. And in terms of sensitivity, which is the probability of detecting cancer when cancer is there, when you inject contrast in breast CT or really breast MRI as a competitor where contrast is always used, it turns out that the solid tumors that most breast lesions are, they attract the contrast agent and they accumulate the contrast agent. So it's really unambiguous. Even to a non-physician, you could look at the image and go, wow, that lesion is picking up contrast. And that's likely to be a result of angiogenesis and is likely to be a tumor, a malignant tumor. Now that we have this beautiful scanner standing in front of, I think that it's really ready for industry acceptance and for especially the clinical radiologists' acceptance. It will be my life's greatest success professionally to have the isotropic scanner, IsoView, in my laboratory scanning patients. Nothing could be more satisfying career-wise than that.